So my name is Kim Hanson. I'm an associate professor of medicine and pathology at the University of Utah, and our affiliated clinical lab is called ARUP. So I have a great job, and I love it. I spend about half my time in the clinic or in the hospital seeing patients with infection. My clinical expertise is in the area of cancer care and transplant-related infectious diseases. So these are patients who have complex medical problems and are at really high risk to develop antibiotic-resistant infections from all that they've been through in their care history. On the other side of the street, in the clinical lab, it's more of an administrative position. I help to oversee diagnostic testing for patients in our hospital. We're also a national reference lab, so we receive specimens from hospitals around the country to help diagnose infectious diseases. I use diagnostics in a variety of different ways. On the clinical side, seeing patients in the clinic or in the emergency department, I'm often the person who's ordering the test to try to determine, does this patient have an infection, if they're infected with what, and to help me make decisions in real time. So really for diagnostics to be useful for me in the clinic and in the emergency department, ideally I want an answer within an hour or two during that patient visit so I can inform how I'm going to help manage the patient. And it's become very relevant in an era of antibiotic resistance where we really want to know if a patient has a bacterial infection or a fungal infection and whether or not they really need an antibacterial or antifungal. We know that overuse of these drugs is what contributes to the resistance problem. In the transplant setting too, these drugs are life-saving. We often use what we call prophylactic antimicrobials where during a period of risk when their immune system is weakened by the transplant or the cancer chemotherapy, we put them on antibiotics or antifungal to try to prevent infection. It's effective often, but guess what happens? Sometimes we see infections that break through those preventative medicines and they're often resistant to our first line choices. So being wise about how we use drugs in the clinic, in the ED, both to optimize care for that patient, hopefully prevent the development of resistance when possible, and also avoid unnecessary toxicity from medicines that they might not otherwise need. I'll tell you, there's a huge unmet need for diagnostics that can give us accurate information in a rapid time frame, and we'll probably talk more about that in our case study today. On the lab side, what we do is perform tests for patients in our hospital and around the country. We use a variety of different tests. We may purchase tests from a commercial vendor, things that have been cleared through the FDA, but there are many diseases for which there are no commercially available options. So a lot of what I do with my team is to develop new diagnostic tests for infectious diseases, trying to fill that gap of unmet need where there is nothing available on the market. We call these laboratory developed tests. Our funding comes to do this from a variety of sources, including our hospital and our labs, but also the National Institutes of Health have been critical in funding diagnostics research and advancing kind of basic technologies that have led to new innovations. I'm proud to say I think I've collaborated with every institution on the panel here in terms of research. With the CDC in terms of emerging infectious diseases and rapid diagnostics, Zika was the perfect example there that had impacted my state and a patient in my hospital. With BioMiraU, I have an NIH-funded grant to develop new tests for patients who we think have bloodstream infections using technology that actually came out of the University of Utah and had since been purchased by a diagnostic company, but they've maintained their academic partnerships and research. And the New York State Public Health Department, we perform testing for patients in New York State and work very closely to ensure that our tests are up to the standards of accuracy, efficacy, and safety for all patients. But New York is really leading the forefront, I think, in terms of what they require a clinical lab to show in terms of efficacy and safety of diagnostic tests. So I run the gamut from the lab side, a clinical lab, and from the hospital side, and we'll talk more about how we're using these tests in a care management scenario coming up in the hour. So I'll stop there.